The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's Tuesday morning, and we have a wonderful guest this morning. Do you have to get up bright and early?
Yes, today we have Dr. Beth Gallant, and the topic of discussion is going to be private practice is alive and kicking still.
Dr. Gallant is a well-known pediatrician amongst the pediatricians of the American Academy of Pediatrics. She's the immediate past chair of SOPM, and she runs an independent practice out in Oregon, which is more of a rural practice than a suburban practice. One of the things that really interested your wife, Delia, about Dr. Gallant was her experience with a locums tenens. She took a month, I think, off. And I'm fascinated by that journey. So welcome to the show, and thank you for getting up so early on the West Coast.
Thank you for having me.
Yes.
If you don't mind, Beth, I'll call you Beth, and you call me Herb. We always ask this, the first thing we ask is, why did you become a pediatrician?
That's a great question. When I talk to my mom about it, I say, pediatrics chose me. I don't know that I really chose it. Same goes with medicine. I got into it in a less traditional way. I originally wanted to be a marine biologist since I was 9. And then I went to college and studied marine biology, and it just wasn't exactly what I thought it to be. And I looked around and I thought, what else is everybody doing over here? I had really great grades and was competitive with the pre-med kids. And so I shadowed in an ER. And I thought, this physician is making a huge difference for her community. She's making an impact on lives. I'll pray about it and throw some applications out there and see how it goes. So really not the traditional medicine route. And then similarly, when I went to do my rotation in medical school, pediatrics was the first rotation that I did. And I thought, oh my gosh, rotations are so much cooler than traditional classroom work. And then as I went along, I think in the 6th rotation or so, I thought, no, you know what? It's pediatrics. Holy moly. I love pediatrics. I didn't necessarily plan on going into pediatrics. It rather chose me, thank God, because I love my job. I'm very lucky to do the work that I do and the way that I do it.
I think pediatrics is a lot like marine biology, right? The newborn is like Flipper. I always tell the parents, the 2-year-old boy is like a golden retriever. He likes to play, chase after the ball, eat, and to be hugged and loved. But they're not very smart. If he falls head first into the pool, he's not getting out. So you got to be careful.
What I'm seeing with the medical students that rotate through my office is they come in, and I have yet to meet one that said, yeah, I want to go into pediatrics. It's great. But after they hang out for a month in our office, then they realize, oh, this is a different thing. So I think the mentoring piece is what has been missing.
I think it's huge. Yeah, mentoring is huge. I remember, I think in medical school, our pediatrics portion was maybe 2 weeks. Mm-hmm. And it was, and you just have these snarky moms and these crying children, and who wants to go into that? And I'm like, whoa, you have patients who mostly tell you the truth, right? You have parents who mostly want to do the best they can. How is that not the audience that you want as a physician? Truthful people who want to do the best they can. That's beautiful.
And it used to be the children didn't malinger very much, which is a joy. They don't like to get shots. They don't like to get their blood drawn. They don't like x-rays. They got to be dragged into the office to be seen, as opposed to us adults that we like to complain quite a bit about everything that's not right with our bodies. It is a joyful profession.
I think we got this job in the world. We're rock stars of medicine.
I'm all confused about the AAP. I'm all eternally confused about why they exist, what they don't do. What does SOPM do? In particular, what is the mission of SOPM?
They have a lot of words on the website to describe the mission that you could read, but what SOPM was for me, which I think is, I think there's all these beautiful things online about what an entity is, but really it's like, what does it to each individual person and how is it helpful to each physician? And how SOPM was helpful for me is really having a community of people that I can reach out to when I want to do something new in my practice, or if I want to know what are other people having to tackle, what are they having to deal with, in whether in private practice or not. But I'm not myself out here, guys. I am a solo practitioner. And so it's really difficult to pivot and make decisions just based, some of them are fine, based off just my population and just my practice. But sometimes it's nice to take a step back and take a more global view. And so SOPM provided that support for me. That their mission is not to provide support for Beth Gallant, but that's what they did for me, and I really appreciated it. And less so the corporate sort of vibe and more about relationships, which...
So it was a community. It was the ability to join a community of people that are doing the same thing across the country. And when you don't really know which way to go business-wise, mostly, although sometimes clinically too, someone goes, oh, yeah, I've seen that. This is how I got it. But the reason I get confused is, then what is COPAM, the Committee on Practice in Ambulatory Medicine?
Yes.
So when you read their mission statements and what they do, they seem to be duplication.
There's a lot of cross coverage and blurring and within the AAP that are, and have PAC too, right?
Right. But the PAC, I understand, that's a payer relation.
Within COPAM.
Oh, that's part of COPAM?
I believe so. So there's a lot of branches. There's a lot of acronyms. I oftentimes have to pull out my list of acronyms and go, wait a minute, what's that one again? And sort out in my brain what their specific role is. They each do have their own missions.
I remember back in the day when I started this practice management stuff, people would come with questions, and I'd quickly go on to SOPM. I'd put it out to somebody, Rich Lander or some of those other giants, would immediately tell me the answer. And I go back to, oh, it's so simple as this. Everybody thought I was some kind of genius, but somebody ahead of me, Beth the mentoring, told me the answer. And I think that's where medicine is starting to lose things, because we do what we do best, see patients. And a lot of the giants are no longer practicing. A lot of the giants are no longer on SOPM. I think I'm not of the giant generation, but I learned a lot from the giants, and I'm feeling like I'm one of the last ones.
I think that's how mentoring goes, right? You don't feel like you're a giant until quite late into it, right? I don't think if you ask Dr. Lander, or Dr. Lesson, do you guys think you're giants? Maybe now they would say, yeah, I contributed a lot. But while they were still practicing, I don't know if they would have noticed that themselves. And so it's just part of how it goes.
Yeah. So how did you get into practice? What was your journey like?
So before we go there, I want to know, describe for the audience what your practice is, because it's very different.
Yeah.
Yeah, it's very different. I wish more practices were like it, though, because it's more traditional, I think. So I'm the only physician there. I have no PA, no NPs. I have 2 medical assistants. I have a receptionist who makes my life awesome and amazing. I have a practice manager who is my husband, actually, and massively overqualified for the job. And then really super cool, my mom does my billing. So it's family business.
That's an old school mom.
And are you on a pediatric EHR, or are you in a...
Yes, I use PCC.
Okay. And then, because you're a sole provider, I don't know if you have kids or not, but you have a husband and a mother. What are your office hours so you can have a life and still meet the needs of your patients?
Sure. So I have 2 children. I have a 10-year-old daughter and a 9-year-old son. And my office opens at 8 in the morning. It closes at 5 p.m. I start seeing patients between 8:30 and 9 o'clock. I take an hour lunch so I can tidy up my tasks and eat some food. And I stop seeing patients. I think my last appointment most days is at 4:30. So I can drop my kids off at school in the morning, but my husband picks them up.
And then Saturday hours, do you just meet sick patients or not at all?
I'm from Roseburg, Oregon. I'm from Douglas. I should say I'm from Douglas County. I'm technically in a small town, is where I grew up. But the people here are incredibly grateful for the care that they get. So when I hear stories of other practices, then gosh, our patients will leave us because we don't have after hours and we don't have weekend. My patients are friends and family, and they understand that I have things I would like to do as well. And they're incredibly kind. And sometimes I feel I have guilt about going on a vacation, and they'll say, "Oh my gosh, I can't wait to hear your stories when you get back." And so I'm just really lucky to live where I live, where I have a community that supports me as well in my business.
Yeah.
And then for emergency medicine and hospitalizing kids when you need, what do you do?
Originally, when I bought my practice, I did hospital hours as well and coverage. But then, or actually before I bought my practice, I'm going to tie back into how I got into private medicine. Let's see, timeline wise. I think I've always wanted to go into private practice. I don't think that was ever a doubt in my mind. Even just in rotations and residency, it's pretty obvious working for yourself is the way to go. So the hospital contacted me a year out of residency, the hospital here locally. I was a couple hours away working. And they said, "We want you to start a pediatric practice." I said, "I'm just fresh out of residency, but sure, let's go for it." And so I had them build within my contract so that I could leave and not have a non-compete. And so started up that practice. And then they wanted to start a pediatric hospitalist program. So there was a physician literally next door to me, a pediatrician, who they wanted to start the hospitalist program. And so for him to leave his practice, he needed somebody to take over. And he said, "Hey, do you want to run my practice?" And I was like, "Haha, that's hilarious. I'm pregnant. I've got a 1-year-old. Like, that's not happening." But it did. It totally happened. So when he transitioned over to hospitalist medicine, the nurses were having issues figuring out which patient belonged to whom. And so I shifted out of the hospital and no longer do inpatient medicine, which has been nice for my work-life balance, honestly, because waking up at 6 a.m. to go see a couple infants or not, because you just never know. And having my lunch hour open to do the work I need to do rather than having to go to the hospital and have coverage is hard to give up. But it was a good shift for me and have been it. So my patients are cared for by the pediatric hospitalists at our local hospital.
But word on the street, especially on SOPM, is that practices have no value once the physician is gone. So why would you buy a practice?
Oh, great
I
question.
think that's a big misnomer personally, because I already did it twice and it is
I didn't pay a ton of money for my practice. I have friends in Florida who people are valuing their practices at millions of dollars. And so my friends are like, "Gosh, how did you buy the practice?" I'm like, "Sure, Zach didn't pay millions of dollars for it. We got a fair market value for just the actual stuff in the office and the vaccines that I bought from the prior physician. And I paid some in good faith money for his reputation. And he was wonderful, by the way. People talk about terrible stories about buying practices and loose ends and yucky things. And the person I bought my practice from was absolutely great. And I paid him as a consultant, I think, for the first 6 months because I was terrified. And I thought, oh my gosh, what if I can't pay my bills? Because there's physicians in town that skip out on paying their staff and paying their rent. And I just thought, oh, I can't be that person. And every nickel I paid for my practice was worth it.
Yes, I agree. So I guess this is where that term alive and kicking in private practice came from. It's stories like this. I love it. This is the way it's supposed to be. But you didn't go into private practice right out of residency, did you?
No, the closest I could get to home was about 2 hours north of where I am now.
Right.
And I signed on with a hospital-owned clinic, and it was okay. And then I got poached from my local hospital to start a hospital-based clinic, and that was not great. And so when this other physician asked me to buy his practice, it was great. It works out great.
Is it very fit? And so tell us about how you went about recruiting your locums and your 1-month vacation and that whole experience, because it's fascinating.
Sure. So typically I take a week or two off per year, like a week block. I'll take a long weekend or whatever, but typically only take a couple weeks off a year. And that had been working well for us. But my husband had this dream to motor home to parks in the Southwest US. And you just can't do that in a week for sure. And we started looking into options for me to be gone a month. And it was terrifying because, like I said, my practice are my friends and my family, and to leave them with a stranger would be scary. And so my sister actually worked as the locum out of residency, and she made friends and connections, of course. And her close friend is she consults for the VA, is what she does, but she sometimes can take on locum jobs. And so about a year before we wanted to take our trip, we got in touch with her and said, hey, is there any chance you could come out and cover for me? And she took a look at her schedule, and we had a few conversations to make sure that we both shared the same outlook and that our culture of medicine would work well together. And we went for it, and she covered for me for an entire month. She lived in my house. She drove my car. She took care of my chicken, and it was awesome. There is nothing that I would change about the scenario at all. It was the most seamless transition, I think, in history, maybe. It's a bold statement, but it was so easy. And she could call me anytime if she needed to. My staff could call if there were issues. We told everybody, like, just don't hesitate. We're going to try something weird and new, but we're going to go for it and see how it goes. And we're actually planning to repeat that this summer, I think 2 or 3 weeks to go to Yellowstone.
So I guess this person became part of your practice.
She did. She's part of our family now, actually. So,
which is great. That helps with work-life balance for you, because truthfully, with your hours, if I was interviewing at your practice, well, boy, you work a lot, doc. I can't do that. Work-life balance. Not me, but the candidates would say that.
Yeah. You got to be flexible and figure out what people need at any given time, because it changes.
Yeah, I'm not sure how long you've been in private practice or in practice. Over time, did you ever work in the paper world or straight into computers?
I think my first year residency, maybe we had some papers, but no, I've always had EHR.
Yeah, so you've never seen how a practice would run with paper, how it transitioned into an EHR and so forth, right?
Actually, you know what? Now that you mention it, I did rotate with a pediatric office that had paper in it was medical school.
Yeah.
I mean, it was quicker.
It was quicker, but we didn't write anything.
No.
We didn't write anything. And, truthfully, a lot of those 90214s probably were 213s on the paper version. If you did too much writing, you were inefficient. But since you're in private practice now, what are some of the biggest challenges that you think you're seeing in private practice? Staffing, doctors, mid-levels, time off?
I think my biggest woe currently is mental health care for patients. I don't know about you, Parks. I am inundated with adolescents and teenagers that are addicted to their phones, who are not physically isolated, but very socially isolated, and trying to provide care is daunting. I would say that is it's actually, clinical woes rather than business administration. There's been ups and downs with that, right? There's always something. Getting bait Boris was difficult last year, and my patients didn't really want it. It was nice that people were banging down my door when I couldn't even get it. But let's see what else. Staffing was an issue for a hot minute, but I'm really loving my staffing right now. So really, it's providing mental health care, protecting myself, because I've done a bit too much of it and gotten very sad and tired. So having to say no is sometimes really hard.
Yes.
And so what are your resources? Like, I don't know, like your hospital is big enough that they still take care of kids and inpatient. In Northern Virginia, the community hospitals have all abandoned pediatric inpatient and ER. It's only the children's hospitals do it anymore. So if you have a kid that needs an emergent psychological evaluation, is there a psychologist, a psychiatrist in town you can call?
No. I can call somebody in Portland, which is 3.5 to 4 hours north of here. They have a phone line that I could call if I need help. But if they're in a crisis, it depends how bad it is. If they're acutely suicidal and trying to kill themselves, I send them to the ER and they'll put them on a hold and put them in a room to keep them safe. If it's a kid who they're not trying to kill themselves, but just saying, gosh, I'm having some dark thoughts and I don't know if I can be safe. Sometimes I'll tell the parents you have to just exist with your child until this, and here are some red flags to take them to the ER. But in Douglas County, we have really minimal resources. We have minimal people prescribing to children, not children, but adolescents mostly. We have a few very good therapists, but they're overbooked and underpaid.
The therapist, probably even in Long Island, nobody takes any insurance. And if they do, you can't get an appointment but in 4 months. What are we supposed to do with this?
I'm lucky in that because I have such a small community of people, I have some phone numbers that I can call or text and say, hey, I've got a kid. I really need help on this one. And sometimes they can leave them in, which has been really nice. But without those relationships, I wouldn't be able to help my patients much.
And I have another clinical question. At least here, every year, the thought police changes my language, so I'm trying to be careful. But that the overweight and obese stage 2 and 3 seems to be taking a big part of the clinical time. Like I dread an adolescent female well child exam. It's never just a well child exam. There's always anxiety or depression or something, some relationship problem with the mother. And it's, oh God, that's going to take me 30 minutes. That's not scheduled for 30 minutes. And then the other third of the time, I play an endocrinologist on YouTube. It's the obese patient, the pre-diabetics. We have this clinic that I help. This year, they've had 3 type 2 diabetics and 1 type 1. It's an avalanche, it's a tsunami. And even though we have a lot of resources because we're a big metro area, it still takes 4 months and 9 months to see a peds endocrinologist if you don't have type 1, 500 glucose with ketones, you need to be admitted to the hospital. Are you seeing that out in rural and the West Coast too?
Yes. Our wait time to see an endocrinologist is much more though. And I feel like there's a heavy leaning towards trying to get us to manage it. Type 2 diabetes, definitely, they're not getting seen.
Well, I think, I'm sorry to interrupt you, but I think we have to step up. There's only 1,100 pediatric endocrinologists across the country, and they're all overwhelmed as it is. And it's all the same problem. It's a problem that Medicaid does not pay enough money for the children to be seen, and 50% of the children are on Medicaid. And if you're not in a procedural based science or career, and you don't have a heavy insured population, then you're treading water. And I think the endocrinologists, the peds, our friends in peds endocrinology have it worse because at least we get some easy stuff of the bronchiolitic or the ear infection, or once in a while a diaper rash, or the mom just thinks that this rash is really dangerous and it's hand, foot, and mouth disease, and it's an easy, quick, and it's going to get better. But the endocrinologists, there are no 10-minute visits for them. I don't know how you do a type 1 diabetic, look at their data, look at where their numbers are, counsel them, adjust your insulin in 10 minutes and move on.
So you can't. 10 minutes and move on is not realistic.
No, but so what do? They're pressed. They have the same thing, but much more complex patients. So I find that to be very distressing because I think most pediatricians were empaths, and we want to take care of our own, I was going to say a bad word, but we want to take care of our own house but not do any harm by giving the child the best person for that disease they have or they're living with. And it's hard when I see all these obese children or these kids with type 2 diabetes and the teenage girls are struggling tremendously. And how do we take care of them?
It's starting to become a general pediatrics, like always, it's becoming a general pediatric issue to deal with. And I don't think we can learn about it. We manage ADHD, I personally don't like doing the anxiety, depression, but I'll refill a medication that was prescribed by somebody else. But I shouldn't be the one managing anxiety and depression. That's not my thing.
I do manage anxiety and depression because there's no one else to do it. So I did a couple conferences from psychiatrists to learn And I have some pretty decent boundaries. I will prescribe fluoxetine and sertraline, but I don't go into the atypical antipsychotics. I don't branch out into ones that we have at the conference I went to. One of them was really good about what we're going to do as a first step. You can do the first step while you're waiting for a referral. And if the first step works, then great, go with it. So I do think we need to be flexible and adjust to the needs of our patients. But if I didn't do it, it would be catastrophic, guys. It would be catastrophic.
Yeah. The problem there is the payment. And you know this well, George, because there's two partners in your practice that do all of this chronic disease management. And these are complex, time-intensive patients, and the revenue is not there. Especially if you're a solo provider, there's not three other people seeing the easy stuff fast to compensate for the more complex stuff. It's a big hit. And the only solution is better payment. We need to pay the pediatricians and the family practitioners what we really deserve for doing the work that we're doing. And especially when you're a solo practitioner in a smaller town, that if that practice goes under, there is no backup. In my neighborhood, there's lots of other pediatricians. If I stop seeing patients, there'll be a longer wait, but there's still someone to see them. In Bayshore, in Long Island, if RBK closes tomorrow, Juan Spinoza will take some of the patients. Allied will take some of them. But in these smaller communities, Beth closes the door, no one's coming.
Yeah. I hear what you're saying with the more payment. I agree with that. There's always better. But I think the burden that physicians have with anxiety and obesity and all these chronic diseases is not so much, could you get to work with a patient that has anxiety and do your job and prescribe whatever medication you need to do within 30 minutes if you didn't have to write anything?
No. And, George, man, I love that idea. I know.
That's where it's at. That's where it's at.
AI scribe, it's terrifying.
Yep. I've been
one day and I'm like, oh my gosh, it just really fills in a lot of stuff that didn't.
I get to do checkups, right? You'll see a checkup. You have them fill out the PHQ-9. I find one that's suicidal. Happens all the time. That is, put a gun to my head, Dr. Bravo, when that happens. I had to spend another half hour and this and that and blah, blah, blah. I do my checkup piece. I put on add another encounter. So what's a PHQ-9? Why are you sad? And you start doing your stuff humanistically. It gets all documented. Send them where they need to go, to the ER, to a psychologist, set it all up. And then copy, cut, and paste your entire transcript that you could never, ever in a million years write by hand. And it didn't take me 2 hours to do. It's the medical script. So that's how technology has helped pediatrics office.
So Beth, your experience is different. You tried it and it hallucinated quite a bit.
Yeah.
And it scared you.
Yeah, I thought it sounded very pretty. I thought it was.
No, she said she liked it. She didn't.
Like,
no,
I did not.
No, she did not.
Oh, you didn't like it?
Oh, no, I didn't. It's not the same as a physician typing. And I read it and I'm like, wow, that sounds great. But is it what I would write or how I would write it? No.
I've demoed about 10 of these products just for kicks.
Yeah.
This they're doing. And what they're doing is exactly what the EHR companies did. They made it more complicated, more bells and whistles because the Dr. Bravos want this and they want that and they want that and they want that. You got to get a product that you could use right off the shelf that you can train on in 2 minutes and move on, and it's not intrusive to your lifestyle. If I have to demo a product and get training on it for 2 days, I don't want it. We're using a product that was very simple. I just sometimes I look at the notes and I sometimes wonder, is this really Dr. Bravo? But I know Dr. Bravo doesn't write anything. So I know that it's the scribe.
Yeah. Well, and I think about, oh man, that you were touching on the EHR. There's so much gobbledygook in EHRs that I'm like, what a colossal waste of my time. There was all of this nonsense. And the boxes they were required to check, it is not really relevant to the care, right? And I worry that AI is going to trend that direction where I'm not getting what I need from the note when I'm reading your note to take over care or something. reading a bunch of beautiful, fluffy language that AI has put in there, but is it really an accurate description? And is the succinct description of what occurred in the office visit and what the plan is?
It is a bit of fluff, but it's getting better. And I think it picks it up over time with your style. And let me tell you, I look at it, I use it, and sometimes I wonder, did I write that? Or did the
No, you didn't. You didn't write it. So what bothers me about the AI, and George and I do use a product that's a sponsor of the show, is that I go through the same routine, right? Because I was an ear doctor and we used pre-printed forms so we could bill correctly. And there's 7 questions you ask everybody. When did your disease start? What's a good medical history? When did your disease start? How high is your fever? What symptoms are associated with it? Did you do anything for it? Yeah, I did this. Did it make it better or worse? Is there anything else? Is there anybody else sick at home? It's just common good history taking.
Yeah.
And what I don't like about the AI is that it doesn't transcribe that into my subjective. It just summarizes it. Johnny's here with a fever and cough. That's it. And I would prefer that it would put the 7 elements into there so that if Beth or George see that kid 2 days on the line for whatever reason, they're like, oh, so this is what was going on. This is why he was thinking this way. The kid didn't do better. This is what he did.
Did you just think, or did you actually say the 7 elements?
No, I asked the parent the 7 elements, and it doesn't properly transcribe it.
If you ask it, you have to your style of how you're talking to the patient and asking the questions.
We shouldn't, though, because it's AI. We will ask how we want to ask.
So it's better that I could type away, because there's no way I could type that. And every patient I see, there's just no way.
There is, and especially in this product that we use, you could go all the way to the bottom and you get your full discussion, word for word, dribble that you said in the room, and just drop that in there if you want. You go back to read that.
Yeah.
You go off on tangents and start talking about extraneous stuff. What I like is if you're talking about asthma or whatever and how you're doing, what medicine you want. Oh, how was the soccer game last week? It excludes it completely. You know,
I think it's great potential. I think it does help. You have to understand the technology. This is not smart technology.
It's a tool.
This is not smart technology. This is not wisdom. This is ones and zeros, and it's reading ones and zeros and trying to predict if you do 1110000, 90% of the time, what would the note look like? And that's what they put in there. That's how it really works. And I think it's much better than the current EHR. I think Freed AI is a great product. I think very useful. It allows me to move quicker. But we're in the infancy of this technology, and as it evolves, I think it will be very helpful. What else? What else do you do out there in Oregon? I'm still having a hard time picturing. So you're a solo practitioner, but there's a community hospital that you can admit to that does deliveries. Is there other pediatric practices in town?
There's one other private pediatric practice with a solo physician. But I believe her son is coming next summer. I believe he's graduating and going to join her, which is really exciting. I don't think she's full-time, though, currently. But when her son gets there, I'm sure he'll be full-time. So that'll be good for our community. The hospital-owned clinic had a pediatrician, but I don't think she's full-time. And then the FQHC has a pediatric nurse practitioner. And I think there's a really brilliant pediatrician that works there, but I don't know that he does any clinic time anymore.
What's interesting, we're dominated by large systems and FHQs and clinical that are operated by hospitals. How can a private practice like yours and the other one down the street, how do you guys stay competitive and relevant? You guys are young, vibrant, and you want to do good, but it's still a business.
Yeah, I think everybody's been fishing for quality, right? That's the new cool thing. Right. And I think that patients and families are well aware of what that is. And I think seeing the same person and having a relationship is what my office is selling. I know them. I tell when DHS holds kids, I'm like, call me. I know all of my patients. They're not being seen by anybody else. It's just me, and we know them very well. And people like that. They don't like going and seeing a different entity. So I think that's what we bring to the table. And our ability to shift and be flexible with the needs of our community is imperative. And we can shift much more quickly than a large hospital base. That takes forever to change a hospital system.
Yeah,
Right?
yeah.
I remember I was starting that clinic for the hospital. I had to say why I needed a baby scale. And honest to God, the administrator said, can't you just put them on the scale? Like the big kid scale, just plop them on there. And we had the thing on the wall you have the kid with, that I need one of those. And they're like, no, just use a measuring tape. And I was like, you've got to be kidding me. I will not set foot in that clinic until you have the adequate tools for me to do my job.
Yeah.
I think, gosh, I shouldn't have to do that. So it's those little things that are barriers to providing care. And my practice, we have no overhead and administration that we have to get permission from. I can just do whatever I want. And whatever my patients need is what we're going to try to do. And that's how we stay relevant.
What about access to care? What do you think about that? It's 3:00 on a Friday afternoon, and Johnny comes home from school. He has a fever and he has ear pain. You're closing down.
Yeah.
And your appointment's a book. You're full.
We also know our patients well. And so sometimes we can squeeze them in. We don't want to send our patients to urgent care anymore. Then they want to go to urgent care.
Hmm.
And so oftentimes, and there are times that I can't. There are times that I cannot squeeze in another person. There are times that I can. I can also go to somebody's house if I want to, right? I'm in a small community. I've done house calls. I've met people at my office on weekend because that's what I want to do, right? And I don't do very often. I need my work-life balance too, but the relationships that I have with my patients and their family is a blessing and a beautiful thing, and no hospital system can replicate that.
I guess it's the personal touch that builds these long-lasting relationships with the families.
Yeah, I like to think so.
So, yeah. And then I guess what's going to happen, segue into the next question, is your community involvement. What makes you successful? How do you get successful? How do you get patients? I can predict one way.
She was born there. She's from that community.
Right.
You know,
I'm into that. So
a lot of these people were their grade school classmates or...
So it's word of mouth, right?
There's a lot of word of mouth. We have a great website. I used to do the baby classes at the hospital. And then I don't know what happened with those. I didn't necessarily quit, but I think someone else took over and whatever. What else? We do different things with our patients too that people hear about. We do a roller skating night and we do, gosh, it's not coming to me, but we do different things. Oh, I used to do a clothing giveaway. Your kids have outgrown all of their stuff and they wore it twice. And so we would do in August before school starts or in July even, we would do almost like a clothing swap. So parents would bring their clothes from their kid that they've grown out of and they can just take whatever they want, give whatever they want. We'll do interesting things because we can.
Yeah, but you know what? All these things require doctor time, involvement, and a paycheck, and it generates no income.
It's marketing.
I don't think the clothing swap take doctor time. It takes
and you're the face. You're there, you're involved. You're not a traveler.
I take my kids come into my office. They have, my daughter likes to answer the phone now, which is neat and totally doable. Yeah. So it's a family business, and
it's not all about spreadsheets and dollar signs.
No,
about giving back a little bit, and you'll get more later for sure.
So with all these things that you have going on, you got a mom, you got a husband, you got 2 kids. This is your community. You grew up in that community. Then you're a doctor. Then you're a business owner. How did you find the time to be part of SOPM?
That was really hard. That was really hard. I was on the executive committee for a few years, and then Sue had to step down to be the president, and they needed I really was only the chair for a year. They had asked me to come on longer, and I had to say no, guys. I said yes to the interim, which that was plenty for me. That really overextended me quite a lot. I love SOPM, but that was too much. So I'm glad it was just a year, and it was hard to say no, but It was
But
good.
what was your job? What'd you have to do? I'm on PPAC. I have a meeting with them once a month or so. We talk about stuff, and that's the end of the involvement.
Yeah.
I think SOPM's much larger, and there's a lot more issues that come across.
Yeah.
I
You're onboarding the new
Portal,
listserv
yeah.
option, and I don't know. They're trying to redo the structures and groupings, and I don't know. There's always stuff. You got to review policy statements and articles and
insult.
a lot.
Yeah.
What's that? Yeah.
Yeah.
Why? It's private
No,
practice and stuff. Tell me.
because that's the way the AP works.
When they write an article from an academic standpoint or a policy from an academic institution standpoint, and they want to roll it out and say, this is what everybody should be doing, me, solo practice over here in Oregon, needs to be able to say, hey, that I can't implement that. I'm over here by myself. It is an N of one over here, guys. Like, it has to be doable for me too.
I'm going to have you hold that thought.
Okay. There we go.
I'm not going to explode, I promise, because I'm in the office today. So I have to be, there's kids in the office. But I have a disagreement with Jesse Hackle, where I think the chairs of these committees should get paid so that they have the time to do this. He thinks absolutely not, because this is what he does for charity. He says, I don't go to the synagogue. I don't volunteer in the old people's house. I don't go to the hospital and help for free. This is how I give back to community. And my argument is, if we want younger pediatricians that represent not the hospital, not academia, the rural communities, the communities that are probably underserved in every big city, which for somebody that was from that community that has a small practice, they just simply cannot afford to take a day off from work and lose that income and maintain the business and the access to care. So and Jesse says, we should volunteer. I'm like, but if you do it that way, only the people in larger practices that are older can contribute. And we're not really getting a whole 360 view or involvement, because there's either 33 or 60,000 pediatricians. I don't know. I was just having this conversation with Jesse, because one place said it was 63,000. The Labor Department, the U.S. Labor Department says there's 32,000 pediatricians. I don't know which one's true. The numbers on payment, on salaries, seems more accurate from the Labor Department. So I'm like, Jesse, I don't know which one is true. But anyhow, so I think we have a difference in that. As far as implementing stuff in the office, I'm very frustrated because the AAP is an old arthritic man that moves very slowly.
Oh, very slowly.
And everything is like the U.S. Congress. Here's a proposal from Dr. Bravo. Okay, we're going to send them to SOPM, and then we're going to send them to COPAM, and then the Immunology Committee and the Endocrinology Committee. And these people are all volunteers. So they're like, yeah, this is important. And then the months go by and nothing gets moved. And when you talk about implementing stuff in the pediatrician's office, we don't get to the table when these decisions are being made. So right now, I don't like the term type 1 diabetes. I call it autoimmune diabetes. We know that you can draw the autoantibodies early, 9 months to 2 years of age, and see which kids have insulitis. Out of those kids, 40% to 85% will end up with end-stage pancreatic insufficiency. The community is very strong, because if you live with type 1, if you have a child with type 1, if you had a mother with type 1, it changes your life. And so they're very active, are moving to get screening into the pediatric office. And it's a right thing to do. The data is there because it can prevent 90% of cases of DKA, which is a disaster for a child. We don't have the pediatric workforce to do it. We don't have enough pediatric endocrinologists. And to just stick it a little bit more, I'm going to order tests that I'm going to have to learn how to interpret. And out of every test I order, one's going to come positive. And they don't pay me for reviewing these tests. The well-child exam is a set fee. There's no upcoding for how many screens I did. So I spend easily 30 minutes to 40 minutes when I come into clinic clearing lab results. A lot of them are screening tests. And that's where I get a little frustrated. I'm yelling at the AAP, send some general pediatricians to these meetings because it's the right thing to do. We're going to have to do it. How do we work on it so that the kids win, so that we can get paid, so that we don't have to send every kid to the endocrinologist? Have conversation early. Shape the policy.
Okay.
Don't play catch up like we did with the Beyfortus. We had to play catch up. And here, people wanted Beyfortus. This is one intervention people really wanted.
Yeah.
We couldn't find it. We didn't know if we're going to get paid. We didn't know we could afford it because we were not in the conversation early on.
I think with this diabetes thing, they're going to say, you're not an endocrinologist. We should have the endocrinologist dealing with it. But the endocrinologists don't see the kids that are healthy. That's a general pediatrician that sees the kids that are healthy. They see. So it's a catch right there. Even on SOPM, there was a discussion on this. Why isn't endocrinology making a statement on this? I think it should be the general pediatrics making a statement. We're screening, just like lead.
Right.
You know?
Just like hemoglobin for anemia.
Yep.
Just like for depression. I'm not a psychiatrist, but I'm given a tool with a CPT code that some payers don't pay for it. And when I see somebody that may be in trouble, then I try to help. That's just what we do. That's how we try to prevent illness or identify illness early enough so that we can change the course of the illness. That's what we do. That's a business of pediatrics.
Yeah.
But we can't do it for free.
Yeah.
And it can't be so complicated that people go, no, I can't. How do I do that in my workflow?
Yeah.
I think we need to be in the conversations early, shaping the policy, not wait until it's given it to us and go say, we can't do that.
SOPM does a bit of that. We review these policies and statements. We have the opportunity to do so. And actually, they have started a policy review committee that you could be on if you wanted to.
Yeah, but I'm sure you've read those policy things. Those are pages long, lots of pages.
There are a lot of pages long.
And my attention span is this big.
I can't read all of them, but the ones that I think are applicable or interesting, right? And so if everybody reads what's applicable or interesting to them, then hopefully we have good coverage and good voices to contribute.
I don't know. Anywho, so you're a young doctor. How do you see the future of pediatric private practice over the next, I will go 20 years, 10 years?
Okay. I see some trimming of the fat with hospital administration and in administration in general, right? Less so in private practice. I don't think we have a lot of administrative overhead, but I think that doctors are going to say enough is enough and be empowered, hopefully, because I feel like the support is there, right? So I think we're going to see more private practice. I just can't fathom that people aren't going to see their own value and go out and venture out on their own because they're not going to want to deal with all of the people who've never practiced medicine telling them how to do it. There's just no way. Most physicians are type A personality, and I think pediatrics is going to go very much so the direction of more private practice.
I think, right, because we're meeting more and more people like you, Beth.
Yeah.
I think what you said, your patients don't want to be a cog in the wheel of a huge system. Special with it.
Physicians don't either. Nobody wants to be a cog in a wheel, right?
I think if you have something like some thing in your head that you have to go to Hopkins to see the one neurosurgeon in the country that does this surgery, you're like, I got to put up with being a cog in the wheel. But when it's just, I need my physical, I don't need to be a cog in the wheel. There should be somebody in my neighborhood that knows me, that sees me once a year and says, yeah, everything is going good. See you next year. Right. And I think that's the key. I think that in our practices, in our business line, luckily most children are healthy. And they don't want to be a cog in the wheel, that huge system made for the really sick. They want to be in a very personal environment where relationships are built. And that's the magic of pediatrics. Well, Scott, this has been wonderful. It's great to see you again.
Before she goes, what advice would you give to a young resident that's thinking about practice?
Ooh, yes. I would recommend that they join SOPM. I would recommend that they attend PMI so they can meet people who are in private practice, build their network of people to support them when they go out on their own, and ask a lot of questions of what that can look like, right? You don't have to start from the ground up. You can buy a practice. You can join a practice. There's so many different ways to be successful in private practice. Asking questions of people who've gone before you, because it's rare that you're doing something no one's done before, right? You just have to know the right person to ask.
All right.
Thank you so much for your time. I know you have to do
Thanks for
so
having
many
me.
things. Thanks for all the work that you did at SOPM and the AAP. We really enjoyed the social. I hope to see you again next year in Denver. And most of all, you have a blessed end of the year and a very blessed beginning of the year for your family, your practice, and your community.
Yeah. Thank you, Beth.
Thank you for having me. And thanks for the show, guys. It's always fun.
All right.
Thank you.
Take care.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.